A lot of questions come by that there is about 30 to 50%, probably closer to one third of the patients with MSI-High that will also have a BRF mutation, uh, and BRF V600e or BRF non-V600e mutation. But specifically for the BRF V600e mutation, do these patients behave differently? We know that BRF V600e confers a worse prognosis. Uh, when we look at those patients in at least the nivolumab study that had BRF mutations and MSI-High, they do seem to benefit somewhat from the PD-1 or PD-1 plus CTLA-4, so Nivo or Nivo plus Ipi. But we haven't looked. What we haven't looked at is, of course, and I think it's needed, although it's going to be a challenging study, is for those patients, can we introduce the concept of bringing BRF targeted strategies before IO, with IO, or IO first? We know from the Beacon trial that was recently presented at ESMO GI that a combination of binimetinib, encorafenib, and cetuximab, so the triplet RAF, MEK, and EGFR, conferred a significant response and other outcome, so PFS and OS improvements versus FOLFIRI plus cetuximab. Response rate was about 26% with the combo of FOLFIRI plus cetuximab was 2.5%, and this was statistically significant. The hazard ratio for survival was actually close to 0.5. So the outcomes were quite significant for the triplet versus what would have been considered standard, although one would argue that BRAF alterations confer lack of response for EGFR inhibitors. So the question is, for that subgroup of patients, do we expose them first to the encorafenib, binimetinib plus cetuximab before introducing the immune oncology agents, so the PD-1 inhibitor or PD-1 plus, or should we start first with the immune agent? And again, as I said, there's the possibility that perhaps we could study the combination of the two in a reduced manner. I don't think it's 3+1; it'll be 2+1 or some other combination. So that has to be looked at. This is a very small but very interesting subgroup of the MSI-High that perhaps behaves a little bit differently. I think a very important question is, what is the role of these agents, so the immune-driven agents, into the treatment of microsatellite stable tumors, which are essentially 96% of all colorectal cancers in the metastatic setting. So 4% MSI-High, 96% not. Those 96% of patients do not seem to have or do not exhibit any response to a challenge with these agents, whether PD-1 inhibitors, PD-L1 inhibitors, or PD-1 inhibitors plus CTLA-4. They confer 0% response rate. An attempt to essentially make those tumors more warm or hot to essentially increase their likelihood of responding to these agents started with a study first combining a MEK inhibitor called cobimetinib plus atezolizumab. And this study, essentially in Blaze 370, tried to or attempted to reproduce some of the results, promising results, both in the lab that suggested exposure to MEK inhibitor inflames the tumor and makes it more susceptible to PD-1 and PD-L1 inhibition. And then there was some promise from an early phase 1b study that suggested that indeed there were responses in microsatellite stable. So they put this regimen to the test versus regorafenib, and essentially it failed to show improvement in outcome. If anything, one element was actually worse. The PFS was worse with the combination versus regorafenib. The survival was no better, and the response rate was about the same than regorafenib. So this study unfortunately ended up being negative, and certainly put a little kibosh on this area. Fortunately, there's still some interest in developing strategies to bring those PD-1 and PD-L1 inhibitors into microsatellite stable tumors. Some of these look at different elements that target the similar pathways than the MEK inhibitors, so parallel pathways, um, agents that manipulate essentially the microenvironment, the macrophages, and others that may essentially make PD-1 inhibitors more active in these tumors. And then there's also, the possibility that combining VEGF inhibitors with these PD-1 inhibitors. We had some hints from a small study with bevacizumab and atezolizumab, but we will hear more about results from a study with atezolizumab, bevacizumab, and capecitabine versus capecitabine and bevacizumab at ESMO. This was a randomized study essentially that looked at the combination of bevacizumab and atezo versus bevacizumab along with chemo. So we'll find out more about whether that strategy may be viable. We know there are hints from ASCO from a study with regorafenib and nivolumab in both gastric cancer and metastatic colorectal cancer that were microsatellite stable, that showed that in some of these patients, they've had some significant responses. They did have to cut down on the dose of regorafenib to 80 milligram. Mind you, this was primarily Japanese-only patient study, but the responses were actually quite impressive, especially in the gastric cancer cohort, but they were also really good in the colorectal cancer cohort. So I think at this point of time, we are understanding a little bit more about these combination strategies that may essentially bring immune oncology into the microsatellite stable tumors.